Hello, everyone. Welcome back to Management of DRTB. In this module, we'll be looking at DRTB and HIV co-infection, how we approach patients with DRTB and HIV co-infection. I'm Dr. Abel Greg Mudiba. I'll be the one taking you throughout this module. Now, firstly, we'll look at the impact of HIV on TB epidemiology. There's a journal by Nan P, the 2007 journal, where he looked at different countries with the impact of HIV. And you could look at on this graph that Africa, from 1990 with HIV, the HIV has been going up, because of a lot of factors. And then if you look at other countries like your Eastern Europe, it has been slowly escalating the HIV, whereas all other countries except Africa, it's been slightly going down. So it shows the impact of HIV in Africa, that we're having a bit of a problem. The TB incidence in HIV or in Africa, it's been going up. Now, why TB and HIV together? Now, on my slide here on your left, you could see we have macrophages and CD4 lymphocytes that are naturally barriers to tuberculosis. So these are some of the components of your immune system that helps you to fight TB. You remember, your immune system would have to be low, meaning these guys, your killer cells, your helper cells, dendritic cells, your eosinophils, B cells, neutrophils, they have to be very, very low for the TB to get into your system. So when these guys, your monocytes, your macrophages, your killer cells are strong enough, they could have an impact or be a barrier for TB. Whereas when you look at it in the context of HIV targets these guys who are barriers for TB, but HIV loves these guys. They attack these guys and decrease the immune system. So it doesn't necessarily cause them a barrier, just like for TB. So HIV for these guys causes a decrease in their numbers. Now, in terms of the HIV infection, I will illustrate it through this train here on my diagram. In terms of its speed and distance, and look at there are some of the factors that affect or influence HIV through the demonstration of this train. Now, with this train, you will need a speed of it to get through this cliff, and obviously the distance the train will travel to fall into this cliff, and then obviously the brake system will also have to play a role. Now, all these factors would have an impact in terms of how quick this train will fall inside the speed. So these are the three factors: the speed, the distance travel, and the brake system. Now, what am I saying in terms of these three factors? How does this relate to HIV infection? Now, to understand the terminology properly, with this diagram, viral load represents the speed of the train, the CD4 count represent the distance of the cliff, and the immune system or the antiviral therapy represent the brakes. So what am I saying? I mean, the higher the viral load, the faster the speed, the higher the viral load. The shorter the distance, the lower the CD4 count. And then if the brakes are working properly, it wouldn't get to this cliff. So if the ARVs are controlling properly, then the train wouldn't be going down the cliff. It would, even the distance might also increase in terms of the CD4 count. The speed will be lowered because the immune system will lower the viral load. So the speed of the train will be lowered for it to get into the cliff. So this is just an illustration in terms of how HIV works inside the system of a human being. Now, our focus will be now in terms of the ARVs in the context of HIV. Now, you You might be familiar with this guideline, the 2019 ART clinical guideline. So the aim is not to revise this guideline, but to we look at the critical issues when it comes to each co-infection with TB management, and what are the issues and the challenges we would face. A year or two ago, there was an introduction of dolutegravir, DTG, one of the integrase drug. Now, everybody was excited about this drug, but what was the excitement about the DTG drug? Now, it was included as part of an FDC to the tenofovir, combined with the tenofovir and lamivudine, which made what we call your TLD, and it has shown and been proven to be a very potent ART regimen. And the other point about dolutegravir, which made everyone get excited, is its superior efficacy, and then its faster rate of viral suppression. I mean, people were saying it can suppress the viral load as quick as 6 weeks after it's been started. So that's how fast its suppression could be. And it's very well tolerated in terms of its side effects. Doesn't have so major side effects. So it's well tolerated in terms of a patient. And it's got a very high genetic barrier to resistance. So it takes time for it to fail. Unlike your normal equivalents where with one mutation is gone, dolutegravir take a while with multiple mutation for it to fail. I mean, some of the patients have to be on it for a duration of 2 years. I mean, even if they are not virally suppressed, for it to try to fail. So it's got a very high genetic barrier. And the other good thing about the dolutegravir was the lack of its interaction with contraception. You remember equivalence, which is one of the drug on the TEE, it's got an interaction with contraceptives. So that was one of the challenges with most of the female patients who have at a reproductive age, where they will use the contraceptive, and it would have an impact in terms of their family planning. Now let's look at the DTG in its own context in terms of its dosage and formulation. Remember, as I said earlier, for the DTG or dolutegravir falls under the integrase inhibitor class. So it's got a standard dose of 50 milligrams. The good part about DTG, currently in the public sector, we have the 50 milligrams. But you might realize even in private sector, they've started with the 5 milligrams for children. But maybe it's something for the future for any public sector to introduce DTG as 5 milligrams. But currently we have the 50 milligrams dose. Then who may get the DTG? Children, adolescent, and adults. As long as their weight is up, it's 20 or above 20 kg, we do not giving it to patients less than this weight. So they have to be equal or above this weight. Now, it comes as a 50 milligrams tablets. So as I said, for children and adolescents with a weight of 20 to 34.9 kg. It also comes as a fixed dose combination of TLD, tenofovir, lamivudine, and dolutegravir, prescribed for patients with a weight of above 35 and an age of above 10 years of age. So in relation to TB, especially the drug susceptible TB, dolutegravir, because of its interaction with rifampicin, you have to double dose the DTG. So you're gonna give the TLD in the morning, and then after 12 hours, you give the DTG dose, 50 milligrams. So that's how you're gonna be giving. You're giving the TLD in the morning, and then after 12 hours, you give the 50 milligrams after the TLD dose. It's in drug susceptible TB, not in drug resistant, only drug susceptible TB. Now, this diagram illustrate in terms of the eligibility in terms of TLD. So this was illustrated with women or adult girls or of childbearing age, and then they determine in terms of its pregnancy status and fertility intention. Now, previously, when they introduced DTG, there was a challenge in terms of its neuro tubal defect. And then what was highlighted earlier was women have to start DTG from, if they are pregnant, they have to be from a gestation of 6 weeks gestation for them to qualify for a dolutegravir. So if there were 6 weeks or less, they would have to be, you recommend TEE because of its effect of neural tubal defect. Whereas if they were above 6 weeks, meaning they are 7 weeks and onwards, these women, they could qualify for TLD. But now, with the recent studies, it was found that the TLD currently now is safe even during pregnancy, so but you have to still cancel the women. So this was the initial plan. So, but now there's with latest research, we are shown that it could be used even in pregnant women with earlier gestation. Now, sorry, as I highlighted, adult women and adolescents, they have to have a weight of above 35 and be above 10 years for them to qualify for TLD because it's an FDC formulation. Now, let's summarize the first line regimen of neonates, infants, children less than 10 years, people aged 10 years or older, especially the adolescent and adults. Now, in terms of children with a weight of 2.5 and they are less than 4 weeks of age from birth, these neonates qualify for zidovudine, lamivudine, and nevirapine. Because of this gestation, they can qualify for abacavir and Kaletra. But now, when their weight now becomes above 3 kg, now these children now, or these infants, they can be converted from A18 triticinograpin to abacavir, 3TC, and Kaletra. So these ones, in terms of when you change them from year to year, doesn't necessarily need a viral load suppression. So you could change them based on the whatever viral load they have. But now, when these children they gain weight and their weight equals to 20 kg or more, these children now they can qualify for DTG. Now remember, this it's unlike here. These ones now that you have to, because you're changing one drug, you have to now look at their viral load. They have to be suppressed for them to be changed to DTG. So the moment they gain 20 kg, they qualify for DTG. Now, these children, when now their weight is above or equals to 35 and they are 10 years and or above, these children now they can qualify for TLD. So this is the summarized sequence in terms of how these children converge in terms of their ARVs until they get to TLD. So obviously you have to integrate your ART services with your family planning. It's very crucial so that you don't have to disintegrate the program where the woman will come the other day for family planning and some other days for ARV services. So it's better at your facility to have both, and the woman takes it on the both day, on same day. Now, in terms of switching between equivalent and DTG, especially when patients are virally suppressed, it's very important. The principle in ART says never change one drug in a failing regimen, meaning never change a patient's one drug in a regimen when the viral load is elevated. So a single drug switch will need a viral load to be less than 50 copies. So with because of the dolutegravir, our viral load suppression needs to be less than 50. You remember previously It used to be 40, 100, 20. So now it's constantly, it has to be 50, less than 50 copies in the last 6 months for a patient to be switched. Now, remember also, it's important to counsel the patients about the risk and the benefits of dolutegravir and efavirenz and its risk in terms of neural tube defects with in subsequent pregnancy, especially with women of childbearing age. But we just highlighted that point in terms of the neural tube defect. But provide the women with the contraception postpartum, So these women have to be told about the family planning in terms of contraceptive and explain or check also the drug interaction, which is very crucial. And we'll also highlight some of it later on with the slides, and warn the client about the new side effects that may be experienced when switching to new drugs. So it's always important whenever you give treatment to counsel patients about the possible side effects. That makes their life of the patients much easier and easier to tolerate the regimen. Now, offer patient the choice of remaining on efavirenz or switching to dolutegravir. So always give the pros and cons of both these drugs and let the patient give or choose from those choices. Now, let's look at this table. It looks a bit busy, but I'll just try and summarize it. It looks at the second-line ART regimen for adults with confirmed viral load or virological failure. So we'll start on the first-line regimen. Now, patients who are on NNRTI-based regimen, we mean your efavirenz and your nevirapine. So these patients, when they are failing a treatment or their viral load is high, we do not need to do the resistant test on these patients because they are on your NNRTI. They don't need to be done a resistant test. So resistant test is not applicable on this patient. So when they are failing treatment, it's always advisable because they are taking tenofovir to check your hepatitis B statuses. So if it's negative and you want to switch this patient, you could safely remove your tenofovir because they have hepatitis B negative. So they'll be on your zidovudine, lamivudine, and dolutegravir. All right, because you have moved to drugs that were not working. So if they are not suitable for dolutegravir for whatever issues, whatever, maybe the side effects, whatever, you could remove your dolutegravir and replace it with lopinavir over ritonavir, which is also known as Alovia or Caledra. But in instances where hepatitis B is positive and these patients are failing treatment and you have decided this patient needs to be switched to another regimen, we have to include the tenofovir with our regimen. So the patient will take 4 drugs. It will be tenofovir, zidovudine, lamivudine or FTC, which is emtricitabine, and dolutegravir. But now if they have a problem with dolutegravir, then you could add your lopinavir, ritonavir without your AZT with the inclusion of tenofovir, because there was a study that was shown that these, if they're effective, they could have a suppression on the patient. So you could still give it without zidovudine as long as there's a lopinavir, ritonavir. All right. Now let's look at instances where a patient has got tenofovir, lamivudine, and dolutegravir, and they've been failing for a period of more than 2 years because dolutegravir has got a high genetic barrier. So less than that, they might not be failing. So you might consider, obviously with the discussion of an expert, you might consider to refer the patient for resistant testing for such patients, but not always the case, but you might have to discuss it with an expert. Now, this patient, because they also are taking tenofovir, you need to check your hepatitis B status of a patient. So if it's negative, you could easily remove your tenofovir and switch the patients to zidovudine, remove your dolutegravir and introduce lopinavir, ritonavir. And if it's positive, you could still have your tenofovir because it's treating your hepatitis B, and you have lamivudine and lopinavir, ritonavir. Whereas with your second line regimen patients who have a PI, protease inhibitors regimen for more than 2 years and they've been failing, these are the patients who, when you're at their PAC level, you refer them to a hospital for resistant testing. So they will need the resistant testing so that the results, when they come out, you send them to a third line committee where they'll determine if these patients qualify for third regimen or not. So they have to be discussed with the third line committee. Now, in terms of TB, when we go back to our main topic, in terms of the TB, the timing of ART initiation for patients not on ART at the time of DRTB is very crucial. So you need to be aware when to start ARVs or ART in a patient with DRTB disease. Now, what is important is for person not yet on ART and is HIV positive, treatment of ARVs should be initiated 2 to 8 weeks after starting RRTB. So TB or RRTB therapy always take precedence over ART. So you have to start with ART treatment, drug-resistant TB therapy. Then comes your ART, especially in patients who are not yet on ARVs when you diagnose the TB. But obviously, you need always to look at the CD4 count of the patient. So in patients with CD4 count of less than 50 cells, you should start your ARVs earlier, like within 2 weeks of starting your DRTB treatment. So you started a bit earlier. Now, but you have to also look at it in terms of your RRTB meningitis. So if there is an infection on the meninges, patients have to be delayed for a duration of 4 to 6 weeks after starting RRTB because of iris in the brain. So they might have an increased intracranial pressure and cause a contusion to those patients. So you need to delay for a period of 4 to 6 weeks. Never start ART before the patient is improving clinically and is tolerating TB treatment. So the patient has to be improved clinically and then tolerating the drugs without any major side effects. Now, assessing ART effectiveness at initiation of the RTB, all persons newly diagnosed with RRTB who are HIV positive should have a CD4 count and viral load test at the time of IRTB initiation and after 6 months. So it's very crucial, even if the patient has been on ARVs, but the fact that is diagnosed with RRTB, you have to have what you call an entrance of this blood, a CD4 and a viral. So we need to know their viral load when they started with the RRTB. We need to know their CD4 count. I know this might also have an impact in terms of gatekeeping, but you need to highlight in terms of it's a newly diagnosed RRTB so that they are aware of it. Now, after taking it and you realize it's not suppressed, obviously after taking from that baseline, you have to repeat it after 2 months from that baseline to check if, obviously you have to repeat it. Before repeating it, you give adherence counseling on that patient. Now, in terms of tenofovir, remember, tenofovir, they have to look at in terms of the status of the kidneys to see if it's functional before the patient gets tenofovir. So in children or adolescents from 10 years to age of 16 years, you look at EGFR, but they're using a Conahan-Barrett formula. So the Conahan-Barrett formula, it's as follows. It's the height is equal to the height of the patient in centimeters. You multiply by a constant number, which is 40, divided by the creatinine, the serum creatinine that you get from the laboratory. So this has to equal or be more than 80 for a patient to be eligible for usage of tenofovir. So after getting the height of your patient, multiply it by 40 and divide it by creatinine, your answer should be more than 80 for a patient of this age to qualify for tenofovir. Whereas if patients are more than 16 years of age, you could use your EGFR that you're normally given from the laboratory, or the one that you normally calculate with a weight, bracket weight minus age, close bracket, multiply by the constant number, the 0. Or depending with the female and the male, you multiply that number 1.23 if it's a male, female 0.75, and divide by the serum creatinine of that patient. Whereas pregnant women, we don't do any calculation. We look at the absolute serum creatinine that is you normally offered from your lab. If it's less than 85, the patient qualifies for turnover. But if it's above 85, it's not eligible. Just because the reason we don't look at the calculated is because all this calculation might require weight, and in women or pregnant women during pregnancy they gain weight, and it might not be a true reflection of that. So that's why we take the serum creatinine of these women for them to be eligible for turnover. Now let's talk more about bedaquiline. Bedaquiline is one of the drugs that is used for DRTB. It's an antimicrobial which falls under a class of diaryl quinine class. It was first described in 2004, first time described in 2000. And in its mechanism, how it works inside, it inhibits the ATP synthesis in the mitochondria. So it stops its synthesis or formation of ATP in the mitochondria. And it was approved by the FDA in 2012 to be used in DRTB. And what is nice about it, it was the first anti-TB medicine in almost 50 years to be discovered. Now, in South Africa, it was introduced in 2013 as a bedaquiline clinical access program. So they took 200 patients and they used the bedaquiline on those 200 patients. Following that success of these 200 patients through the bedaquiline clinical access program, the TB program saw it unethical to keep restricted access to this drug. So they saw its effectiveness. So what they did is they expanded this program by March 2015. So it was expanded from 2013. Now in September 2013, it was a universal access for bedaquiline. So that's how it was easily accessible from 2018 to be accessible to any patient with drug-resistant TB to be given bedaquiline. Now, one of the journals that was written by Elim M. Svensson and Francesca Wicker, it looks at the model-based estimate of the effects of equivalence on bedaquiline pharmacokinetics and suggested dose of adjustment for patients with co-infected. So it looks at this thing in terms of patients with co-infected with HIV and TB. Now, what has to be reminded is what happens is bedaquiline, when it gets metabolized by this enzyme CYP34, and after it metabolizes, it changes to M2. But what is very important is this enzyme can be affected or impacted by the what we call CYP3 inducers. Though there are those inducers that have an effect on this, and there are inhibitors that have an effect on this. But now let's look at how these affect in terms of relation to bedaquiline. Now, if you have your CYP3 inducers, they will decrease your bedaquiline exposure. Whereas if you have your CYP3 inhibitors, those drugs that inhibit this enzyme, they will have your increase of bedaquiline, which eventually will have cause bedaquiline toxicity. So you need to be aware of drugs that are inducers on this enzyme, because they will have an impact, especially if you are giving a bedaquiline, they will have an impact on your bedaquiline, they will decrease your bedaquiline. And if you have inhibitors together with bedaquiline, they will increase your bedaquiline and you will have a bedaquiline toxicity. How does this you have an impact in terms of equivalence? Remember, bedaquiline is metabolized in the liver. Okay, the main enzyme involved in this metabolism, as I highlighted, is a cytochrome P453A4, which metabolizes this bedaquiline into N-monodesmethyl metabolite, which is your M2 that I highlighted earlier. This M2 is 4 to 6 times less active in terms of antimicrobial potency. Now, let's look at the effect of efavirenz. Now, efavirenz is an inducer to this cytochrome. So what does that mean when we relate it in terms of, it means it reduces the beracolin. So if efavirenz induces this cytochrome before, it will have an impact in terms of beracolin, where it will reduce its exposure. So it will not work as effectively as it used, because it will be reduced in terms of its exposure. So efavirenz is an inducer to this cytochrome enzyme. So as I highlighted, just because if you give patients efavirenz and beracolin, they might have a reduced exposure of beracolin by of 50% of it, okay, if it's administered together with efavirenz. So based on these studies, efavirenz is contraindicated with patients on DRTB on beracolin. So if you have a patient that you are putting on beracolin and then is HIV infected, you should not put them together with efavirenz, because it will have an impact on beracolin exposure. It will decrease it by 50%. So efavirenz is contraindicated in DRTB. So this was one of the studies that was shown also in terms of prescribing. So they looked at an increased risk of death seen in patients with Citoro. Citoro TM is your beracolin treatment group. So they look at it, they compared it to placebo treatment group. And in any one of this placebo controlled trial, only those using the Citoro when an effective treatment network cannot otherwise be provided. In this cases, only the use of Citoro groups. Now, obviously, remember the QT prolongation can occur with Citoro, with beracolin. So it could also affect on QTC prolongation. So with the use drugs that prolong the QTC can cause addictive QTC prolongation. So you need to look at any other drugs that causes QTC prolongation. So with that, they look in terms of its indication and its use, that Citoro or beracolin is a dialquilin antimicrobial drug indicated as part of a combination therapy in adults more than 18 years with pulmonary multi-drug resistant TB. So that's how it was found. And it reverses Citoro or beracolin for use when an effective treatment regimen cannot otherwise be provided. So it's very effective. So also Citoro should be administered by directly observed therapy. So it should be monitored closely. So with this indication is based on analysis of time to sputum culture conversion from 2 control phase trials in patients with pulmonary TB. So it has a very major effect in terms of your culture conversion when you are using it. So based on that study, administration of Citoro or beracolin with strong P450 inhibitors may increase its systemic exposure to beracolin, and that will result to increased toxicities, which could cause a serious adverse reaction to a patient. So therefore, strong CYP3/4 inhibitors used systemically should be avoided, while Citoro, unless the benefits of the treatment with the drug combination outweighs the risk. So it's very much important to make sure that the drugs that you are using in conjunction with Citoro or beracolin are not your CYP3 inhibitors or your CYP3 inducers. So they will have an impact on this, whether the impact of decreased exposure or impact of increased systemic exposure. Now, what are those CYP3/4 inhibitors? So those are the ones that we need to be aware of, but the strong ones are your ritonavir drugs that you are familiar with using, your clarithromycin usage, they have an impact in terms of inhibitors, your azole in antifungals like your ketoconazole, your traconazole, posaconazole, and fluconazole. These are your azoles that have an impact, strong impact on your CYP3/4 enzyme. Whereas the moderate inhibitors is your imidazole, your ciprofloxacin, your verapamil, your diltiazem, so, and your commonly used erythromycin, and some of your ozone, which are fluconazole and miconazole. So these are the ones that are also having an impact, but a moderate one. With cimetidine also having a moderate impact. But those who have a inhibitor properties, but that are weak, is valproic acid and amlodipine. So they are not so strong in terms of its causage of inhibitors on this enzyme. Now, what about linezolid and zidovudine? Zidovudine and linezolid, both of these drugs causes toxicity on the bone marrow. So they have an effect on your bone marrow. So based on that, AZT should be substituted with another nucleoside reverse transcriptase in person who was on linezolid. The reason because if you're using both of them, you're going to cause problems of bone marrow. A patient will have HB, low HB, low platelets, and then the patient will have low neutrophils. So based on that, patients shouldn't be on linezolid and zidovudine. So if you're obviously there's instance where you can't change the linezolid, so you have to compromise your zidovudine. So remember also TB and renal insufficiency, they can also cause your anemia. DRTB and ART agents interaction. The guideline, the national ART guideline recommended that ART regimen should be restarted with patients who are previously interrupted first-line ART. So if a patient defaulted or stopped treatment while on TLD, when he comes back to your facility, you restart the patient with the same regimen that the patient stopped with. But what is important for patients on RRTB, equivalence cannot be used with bedaquiline. You remember that equivalence is an inducer to the enzyme, which will cause decreased exposure to bedaquiline. Now, tenofovir and therefore even abacavir may have been compromised if a patient interrupted treatment. So dolutegravir will be unprotected if started or reintroduced with tenofovir. So if a patient was on abacavir and tenofovir and TLD, and you have to restart the patients on those drugs, they might have been maybe developed some mutations on this patient. The patient might be only on dolutegravir when you restart. So AZT will still be an effective option to use with dolutegravir on this patient, but the problem AZT should not be used with linezolid with drug-resistant TB. So in this case, you'll have to introduce protease inhibitors with tenofovir or abacavir in this patient with linezolid. But it will be a temporary measure until linezolid stops. Linezolid commonly stops in short regimen after 2 months. Then after 2 months, you can reintroduce your zidovudine on that patient, and it continues with your zidovudine, lemivudine, and dolutegravir. Now, HIV-TB co-infection. Now, the anti-TB treatment have a precedence over ART. It's always the case that anti-TB treatment, you start with it with patients who haven't been on ARVs. But for a successful DRTB treatment, we need an effective ART regimen for this patient. Hence why we preferred DTG on this patient, especially the co-infected one. But remember, equivalent is contraindicated with bedaquiline because of this interaction, because this one is an inducer. If your patient is using linezolid, do not use zidovudine, as both of them have toxicity on your bone marrow, right? Thank you very much.